Dear students, good afternoon. Let me introduce myself. My name is Alexander Nadraga. I am professor of Pediatric Infection Diseases Department and professor of Pediatric. In our department, for foreign student, 5 years foreign student, this year will be only 3 lectures. The topic of the first lecture, or today's lecture, is diseases related to the sore throat. The next lecture will be infection diseases with rash, and the final lecture, last lecture, will be about meningitis. Today's lecture will take about 40 minutes. After that, at 3 o'clock, I invite you to my Zoom meeting personal room, and we will continue our lecture, some discussion, some answering question. Meeting ID and password are printed below. Thank you. The topic of today's lecture is diseases related with the sore throat, pharyngitis, diphtheria, and infection mononucleosis. Virus infection is the most common cause of sore throat. The etiological agent are usually respiratory virus included adenovirus, Coxsackie-A virus, parainfluenza virus. Some of these viruses produce easily identifiable syndrome, for example, hand, foot, mouth diseases related to Coxsackie virus or pharyngoconjunctival fever due to adenovirus. Viral etiology are closely followed in frequency by group A Streptococcus or Streptococcus pyogenes or gas. Strep is more frequent bacterial cause of infection pharyngitis. Gas account for approximately 15 to 30% of all cases of pharyngitis in children between the age of 5 and 15 years. The higher rate is observed during the peak of strep season, which is usually in winter and early spring in temperature climate. This some presentation, picture A and picture B reveal strep infection, strep pharyngitis in children. A little different is picture C. Picture C present also viral but Epstein-Barr virus pharyngitis. There are a lot of score, and there is some presentation for group A strep pharyngitis clinical scoring system. This scoring system includes age between 5 to 15 year, season, late fall, winter, early spring, evidence of acute pharyngitis, for example, erythema, edema, with or without exudation, tender, large anterior-cervical lymph nodes, middle grade fever, it means fever between 38 to 39 degrees centigrade, and absent of usual signs and symptoms associated with upper respiratory tract infection. For example, absence of cough, chorea, or nasal congestion. There's some clinical case. That case shows us practical use previously described strep score. For example, if an 8-year-old child present in December with acute onset of sore throat, characterized by erythema, tender anterior cervical nodes, temperature up to 39 degrees centigrade, and no symptoms of upper viral respiratory tract infection, the likelihood that her throat culture will be positive for gas is approximately 85%. Is very, very high percent. But if even a single feature is absent, the predictive value of strep score falls to 50%. Typically, an episode of strep pharyngitis has an abrupt onset. Fever, headache, abdominal pain, and sore throat are very common symptoms. Throat discomfort may lead to poor oral intake, and the nature history of strep pharyngitis is characterized by spontaneous resolution in 3 to 5 days. But strep infection in children younger than 3 years of age usually manifested with atypical symptoms. Instead of well-defined episode of pharyngitis in the children present with prolonged symptoms of nasal discharge, nasal congestion, low-grade fever, tender anterior cervical adenopathy, and in contrast to spontaneous resolution, a lot of untreated strep pharyngitis in infants with streptococcus have very persistent symptoms. Treatment. You must remember there are several important reasons to identify and treat children with acute pharyngitis due to strep infection. The main reasons are early treatment result in early symptomatic response. Treatment prevent suppurative complication, for example, acute otitis media, acute bacterial sinusitis, cervical adenitis, peritoneal and retropharyngeal abscess. Treatment also prevent non-suppurative complication, for example, acute rheumatic fever. But is it not clear evidence that treatment of gas pharyngitis can prevent the development of other important non-suppurative complications, for example, acute glomerulonephritis? And finally, the also important reason to prescribe antibiotics for treatment for pharyngitis is treatment prevent transmission to infection to uninfected close contact at school and in the family. There are some clinical diagnostic score of strep pharyngitis, but this very interesting film, I saw this film at the last year SPID conference. This from Professor Charles from your hospital, and based of signs and symptoms diagnosis strep pharyngitis is not very accurate. 50% of patients with pharyngitis will be treated by antibiotics, but will not be infected with group A strep infection. And 30% with pharyngitis will not be treated, but will be infected with group A strep. This film presents which important is lab investigation to confirm diagnosis strep pharyngitis. This film presents a rapid antigen test process. In the test process, a throat swab is subjected to a chemical extraction of carbohydrate antigen unique to group A strep. The test stick is then placed in the extraction mixture and the mixture migrates along the membrane. If group A strep is present in the sample, it will be from complex with the anti-group A strep antibody conjuncted color pitches located in two separate locations on the test stick. The complex will be bound by the anti-group A strep capture antibody and will be visible blue test line will appear to indicate a positive result. A red control line will also appear to indicate the test is valid. Many or most sources recommended that when the rapid antigen test is used, the doctor should obtain two swabs of throat. One is used for rapid antigen detection test. If test is positive, the second swab can be discharged. If the test is negative, the second swab can be used to inoculate a standard culture. In this way, the risk of false negative rapid test result is diminished. And treatment, penicillin V is the drug of choice for treatment of strep pharyngitis, but ampicillin and amoxicillin equally are effective. The dose of orally prescribed penicillin V is 250 mg 2 to 3 times daily for children weighing less than 70 to 27 kg and 500 mg 2 to 3 times daily for children more than 27 kg, adolescent and adult. To prevent acute rheumatic fever, treatment with penicillin should be given for full 10 days, regardless of promptness of clinical recovery. Orally prescribed amoxicillin given as daily dose 50 mg per kilogram for 10 days is as effective as orally prescribed penicillin V. For patients who are allergic to penicillin, a 10 days course of narrow spectrum or first generation oral cephalosporin is indicated, and oral macrolide like erythromycin, clarithromycin, azithromycin is acceptable for patients allergic to penicillin. Treatment is 10 days is indicated except for azithromycin, which is given only for 5 days. Children who have recurrence gastroenteritis shortly after completed 10-day course of a recommended oral antimicrobial agent can be retreated with the same antimicrobial agent, given an alternative oral drug, or given an intramuscular dose of penicillin G. And the next subtopic for today's is diphtheria. Diphtheria is acute communicable diseases caused by Corynebacterial diphtheria. Infection may result in clinical diseases which has two forms: respiratory, cutaneous, and separately forms are asymptomatic carrier state. Corynebacterial diphtherium is an aerobic gram-positive bacteria. 3 biotypes of Corynebacterium, mitis, gravis, and intermedius, are differentiated by colonal morphology, hemolysis, and fermentation reaction. There are also toxigenic and non-toxigenic stains of Corynebacterial diphtherium, and the stains is distinguishable by colonal type, microscopy, and biochemical tests. Corynebacterial diphtherium is exclusive inhabitant of human mucous membrane. Spread is primary by air-borne respiratory droplets, direct contact with respiratory secretion of symptomatic individuals, or exudate from infection, skin lesion. Respiratory diphtheria is the most important clinical form of infection, involves the respiratory tract. Respiratory diphtheria can affect of any part of respiratory tract. Up to 2-3 of cases are tonsillopharyngitis, involves the laryngeal, nasal, trachebronchial areas, is less common. After incubation period, 2 to 5 days, local signs and symptoms reflect the site and severity of respiratory tract involved. The onset of symptoms is typically gradual, with sore throat, malaise, and low-grade fever. Tonsillopharyngeal diphtheria begins with mild pharyngeal injection, but can progress to isolated spot of grade and white exudate. In 30% of patients, toxin elaborate locally induce the formation of diphtheric membrane or pseudomembrane composed of necrotic fibrin, leukocytes, erythrocytes, epithelial cells. The diphtheric membrane is tightly adherent to underlying tissue and result in bleeding with dislodgement, is sharply demarked and is classically gray in color. And very nice old picture. Picture presents the respiratory diphtheria can affect of any part of respiratory tree. Some form of diphtheria, severe form of diphtheria called malignant diphtheria. This diphtheria is associated with extensive membranous pharyngitis plus massive swelling of tonsil, uvula, cervical lymph nodes, submandibular region and anterior neck, and also this form of diphtheria called toxic diphtheria. A respiratory stridor may ensure leading to respiratory insufficiency and sometimes death. Systemic manifestation, systemic toxicity is due to production and dissemination of the diphtheria toxin. The heart and nerve tissue are most severely affected. First is cardiac toxicity. There are also very severe complications of diphtheria. Cardiac toxicity occurs in the second of the third week of illness as pharyngeal diseases improve, but can appear as early as 1 week or as late as the 6 weeks of illness. Clinical evidence of cardiac dysfunction is decreased heart sound, gallop rhythm, cardiac dilatation, dyspnea. These symptoms occur in 10 to 20% of patients with diphtheria. Myocarditis, as evidenced by EKG changes such as STT wave changes, QT prolongation, and first degree heart block, can be detected in 75% of cases. Often occur also when respiratory symptoms are improved. Severe myocarditis is manifested by complex heart blocks and arrhythmia, heart failure, and circulatory collapse. Cardiac complication remains the major cause of mortality. For example, toxic cardiomyopathy is responsible for 50 to 60% of deaths. Neurologic toxicity develop up to 70% of patients with severe diphtheria. Neurologic toxicity develop on the second, third weeks, also after the onset of oropharyngeal inflammation, hyperesthesia, local paralysis of soft palate occur commonly. Weakness of the posterior pharyngeal, laryngeal, and facial nerve may follow cause nasal quality of the voice, difficulty in swallowing, and risk of death due to the aspiration. Cardiac toxicity, cranial neuropathy occur in the 5th weeks and lead to oculomotoral and ciliary paralysis, which are manifested as strabismus, blurred vision, or difficulty with accommodation. Cutaneous diphtheria can be associated with primary chronic non-healing ulcer with digitigrade membrane or with colonization and infection of pre-existing dermatosis. Also, cutaneous diphtheria can be caused by toxigenic and non-toxigenic strains of cutaneobacterial diphtheria. Systemic toxicity is rare. The clinical setting: ulceration, membrane formation as submucosal bleeding help differentiate diphtheria from other bacterial virus infection. Specimen for culture should be obtained from the nose and throat and any other mucocutaneous lesion. Culture isolated of coroniform organism should be identified to the species level, and toxigeneity antimicrobial susceptibility test should be performed for Corynebacteria diphtheria isolated. The diphtheria treatment combined administration diphtheria antitoxin with antibiotic therapy. Diphtheria antitoxin is hyperimmune antiserum produced in horse which bind to and inactivate the diphtheria toxin. The antitoxin is only effective before toxin enters the cells, and for this reason must be prescribed as soon as possible. The dose of antitoxin depends upon the site and the severity of infection. The dose between 20,000 to 40,000 units is indicated for pharyngeal or laryngeal diseases present less than 48 hours. The dose between 40,000 to 60,000 units is prescribed for nasopharyngeal diseases, and the dose between 80,000 to 120,000 units is needed for treatment for a child who was ill more than 3 days of toxic diphtheria or illness of diffuse neck swelling. Antibiotics. Similar to another toxin-mediated infection, antibiotic therapy of diphtheria kills the organism, which slows the spread of local infection and prevent transmission. For this reason, you should prescribe erythromycin. Its dose is 500 mg 4 times daily for 14 days, or penicillin G, 25,000 to 50,000 units per kilogram, followed by oral penicillin V, 220 mg 4 times daily for a total treatment course of 14 days. This is a recommended treatment option for diphtheria treatments. Prophylaxis of contacts. Close contacts need to be identified, cultured, and considered for antimicrobial prophylaxis. If immunizations are not up to date, they should also be given diphtheria, tetanus, pertussis, or diphtheria tetanus vaccine. All contacts also should be treated with 7 to 10 days of oral erythromycin after culture have been obtained. And the last topic for today is infection mononucleosis. Infection mononucleosis is best known clinical syndrome caused by Epstein-Barr virus infection. It's characterized by systemic somatic complaints, consists primarily of fatigue, malaise, fever, sore throat, and generalized lymphadenopathy. Epstein-Barr virus infected more than 85% of world population. It is transmitted in oral secretion, by close contact, such as kissing or exchange salvia from child to child. Epstein-Barr virus may be spread by sexual contact. Epstein-Barr virus is shed in oral secretion for more than 6 months after acute infection and then intermittently for life. 20 to 30% of healthy infected person excrete virus at any particular time, and 60 to 90% of Epstein-Barr virus infected immunosuppressed patient shed the virus. The incubation period in adolescent is long, is 30 or 50 days. In children, this period may be shorter. Patient complain of fatigue, fever, headache, sore throat, nausea, abdominal pain, and myalgia. These symptoms occur during prodromal period. Prodromal period take between 1 to 2 weeks. In this period also we can observe splenic enlargement. Splenic enlargement may be rapid enough to cause left upper quadrant abdominal discomfort and tenderness. The physical examination revealed general lymphadenopathy in most patients, about 90% of cases, splenomegaly in 50% of cases, and hepatomegaly rare, not more than 10% of cases. Moderate to severe pharyngitis with tonsillar enlargement, occasionally with exudatus, is observed in 75% of patients. Petechia at the junction of hard and soft palate can also be observed. Lymphadenopathy occurs most commonly in the anterior posterior cervical lymph nodes and submandibular lymph nodes. These are some presentations of lymphadenopathy in patients with mononucleosis. This is not my film. This film I borrow in AAP. Other clinical finding: rash and edema of eyelid. Rash is usually maculopapular, and rash may be observed in 315 person of patient, but up to 80% of patients with infection mononucleosis experience ampicillin rash if treated with ampicillin or amoxicillin. This rash is probably immune-mediated and resolve without any specific treatment. Symptomatic hepatitis or jaundice are uncommon. There's some presentation of ampicillin-induced rash in mononucleose patients. Diagnosis: CBC. In more than 90% of cases, we observe leukocytosis, but between 10,000 to 20,000 cells per milliliter, which at least are 60% are lymphocytes. Atypical lymphocytes or mononuclears usually observe more than 20 or 40% in total lymphocytes number. It can also observe mild thrombocytopenia between 50,000 to 200,000 per milliliter and occur more than 50% of patients. And mild elevation of hepatic transaminase occur approximately in 50% of uncomplicated case, but is usually asymptomatic and usually without jaundice. The Epstein-Barr specific antibody test is useful to confirm acute Epstein-Barr virus infection. The acute phase of infection mononucleosis is characterized by rapid immunoglobulin G, immunoglobulin M antibody response to VCA in all cases and immunoglobulin G response to early antigen in most cases. The immunoglobulin response to VCA is transient, but can be detected at least for 4 weeks and occasionally up to 3 months. The immunoglobulin response to VCA usually peak late in acute phase of diseases, decline slightly over the next several weeks to months, and this persists at relatively stable level for all lives. There is no specific treatment for infection mononucleosis. Rest and symptomatic therapy are the mainstays of management. And due to blunt abdominal trauma, may predispose patient to splenic rupture, it's necessary to limit some sport and athletic activity during the first 2-3 weeks of illness or while splenomegaly is present. And some physicians recommended prescribe corticosteroids. Short course of corticosteroids, length is 2 weeks. Indicated for corticosteroids include airway obstruction, thrombocytopenia with hemorrhage, autoimmune hemolytic anemia, seizure, and meningitis. A recommended dose of penicillin, of prednisone, is 1 mg per kilogram per day, but not more than 60 mg per day for 7 days, and taper it over another 7 days. It was my last film. Thank you. See you the next time.